Welcome back to our Vessels of Honor podcast. And today I'm joined by Dr. Emma. She's not new on the platform, but in case you're watching for the first time, so I'm just going to ask you to introduce yourself to the viewers.
Okay, great. Thank you, Pastor Emma, for having me. So yes, as said, I am Dr. Emma Chademana. I am a public health specialist, working mainly in the area of maternal and child health. Have also been working in the HIV space for the last 15 years.
Yes, and speaking of HIV space, that's what we are going to be talking about today. So we are going to be tackling HIV. It's a thing that has really caused, a lot of havoc in families. I'm sure most of us, we are somehow related to someone who does have HIV. So it'll be very nice to learn more about the virus and what has been the latest developments in that field. But first, we are going to start with first things first, the HIV testing.
Yes.
I'm going to ask in parts, should everybody just do it randomly, or when you feel you've been exposed, and how do you, can you really say, I feel I've been exposed, or it's a test that one should just do often, or how often it should be done?
Okay. So firstly, so the first thing is HIV testing. Everybody, regardless also of age, gender, race, everybody should get tested for HIV at least once a year.
Okay.
Yes. Okay. So more frequently for pregnant women.
Okay.
And that happens with your antenatal care. At every antenatal care, they take your bloods and they do test in any case. And then if you are in a relationship with multiple partners, you should get tested more frequently.
More frequently than once a year?
Than once a year,
okay.
yes.
Okay.
Or you have been exposed somehow. So either you are in a relationship with a partner that has other multiple partners, or you're just not sure about, you've just been exposed. For example, you've had, say, with a partner, unprotected sex with a partner that you're not sure of, you should always have an
I suppose
HIV
maybe
test.
even if you're sure, just to be 100% sure, then you should just get tested.
Yes.
Okay. So the testing has been done. How do they test it? How do they do the testing? I'm not going to assume everybody knows, but
yes.
What is the procedure actually? Do we get pre-counseling before the test?
Yes. So what we call HCT, which is HIV counseling and testing.
Okay.
So before any test, there is always counseling. Yes.
Okay, perfect.
So what happens is you go into any center, either a community clinic. You could go to a clinic at Discam, at Clicks.
Okay.
You can go to a medical doctor, a practice. You can go to a hospital. Any primary healthcare center, you can get tested for HIV. And there's latest technologies as well. You can get a self-test as well, an HIV self-test kit from Clicks and Discam as well. But for people, we also recommend that you go to a facility, because that's the best thing, because you get counseling there than the self-test.
Exactly. Okay.
So what starts is you get the counseling first, and then once a counselor is actually ready and feels you are ready as well to get tested, then you get tested. So the first test is what we call a confirmatory test, which is the rapid test.
Okay.
And then that is the prick. So that's, you get
Yeah.
results within 5 minutes.
Okay.
And then after that, then you're referred, where you then get your bloods taken. So you have, for example, an ELISA test and other tests that test for HIV in your system.
Okay. And
as
how
well.
long does that one take?
The rapid test is about
No,
5
no,
minutes.
yeah.
Then the other blood tests, usually within 24 hours, you can have
Okay.
your results.
Ah,
Some
that's
within
nice.
48 hours.
So you and are they still saying you need to come back after 3 months? Or?
Yes, you do need to come back after 3 months, particularly for if you test negative.
Okay.
But what we now have is we have a universal test and treat, which is called UTT. So as soon as your bloods actually test positive, you are immediately initiated on treatment.
Oh,
Yes.
I see. Okay, because I was gonna now go to the second part. So I've been tested, fine when it's negative, but if it's positive, how does one handle, that diagnosis?
Wow. It's a lot.
Yeah.
I think usually that's the biggest burden and
Yeah.
the hurdle with a lot of people. So I'm a social scientist. I'm not clinical. I'm not a clinician.
Okay.
So a lot of our work, so with HIV, there's the clinical aspect and then there's the social aspect.
Okay. So
So-
let's talk about the social.
Yes, so that's where the biggest work is with HIV, and that's where we, as social scientists as well, that's where the chunk of our work is, and it begins with when you have a positive test result.
Okay.
There's a lot of feelings. There's a lot. Dealing with a positive HIV result is not easy. I mean, people have known about HIV for many years. We've got family members who've got HIV, workmates. But when it comes to you, when HIV knocks at your door and it's personal,
Exactly.
it's not always easy.
Exactly.
So there's a lot that happens. There's a lot of shame.
Yes.
There's a lot of blame that happens
Yes.
often in terms of who gave me HIV,
Yes.
whether it's your partner, especially if you're in a married relationship.
Yes.
There's quite a lot of fear of stigma, fear of the unknown, fear of death, fear of just even taking treatment. There's also denial. That's the
Yes,
hugest
that's
thing
the
that we
huge
face.
stage.
Denial is quite big. And often we, as social scientists, we also have pressure to try and get people over that, because on
They
the
need
other
to
side
start
there's
treatment.
treatment. And
Exactly.
until we deal with all of this, right? Your chances of success in treatment is really, really a problem. So we actually have to try and support an individual in terms of dealing with an HIV positive diagnosis. That's quite a lot. It is quite a lot.
Imagine.
But
That's a lot.
there are a lot of services out there in terms of counseling, in terms of support groups that people can actually tap into. But it takes a lot as well, and we normally call it provider initiated,
Okay.
where it's up to us as healthcare providers to then try to navigate and support people to go towards that direction. Because at first people withdraw, they go into their own shell and they're trying to think, who do I tell?
Exactly.
And the most important thing at that stage is have a support system, have someone you can confide in. But the critical thing also is it's about who you can tell. It's not going to be somebody who will air your story out,
Yes.
somebody who will respect your confidentiality, somebody who will also support you. But at least we always say to people, tell someone.
Okay. So do you also recommend that they tell the partner first so that the partner can also get tested?
Yes. So,
Yes. But I'm thinking now, you're blaming the partner, and now you must tell the partner and ask them to also get tested, and who gave who. How does one handle, those challenges?
Ish, it's a minefield actually. It is a minefield. So we what we call partner tracing as well. So at healthcare services, once you do test positive, they encourage you to bring your partner.
Okay.
Or you refer your partner. So some, depending on whether it's private or it's public, some even give you a form for your partner to then come to use that form. Yes. So we do try to follow up and trace the partners, so that some have multiple partners. So maybe in the past 6 months, and sometimes it's just, it's not concurrent partners. It could be you were in a relationship previously, then you moved into another relationship, so it's within that period then that you probably you have exposed another partner. So we try to say you need to be honest and come out to your partners. It's difficult, it's not easy. So this is where the counseling comes in, and we always say first deal with the status yourself. Try to come to a point where you are comfortable to then talk about it. But we also try to say there's also the time issue as well. So we need to try and bring in the partner. But we also, I work in communities where there's a lot of patriarchy, a lot of gender-based violence. So we're also very aware of those issues, because most often it's women who are blamed by their partners. Yes, and they're actually
the other way around.
No, I work in the deep rural Eastern Cape. So a lot of the times, sometimes women opt not to go on treatment and not tell their partners actually, because it's a risk on their lives. So there's, then also this is where then a community approach comes in. If willing, if the partner is willing, we come in, we provide counseling, family counseling and family therapy. So
So I've heard cases where we have one partner who's positive but the other one is negative. How does that work?
That's discordant couples, yes. That is actually quite common. Yes. So if you are living with HIV and you are on treatment, you can actually be in a relationship with someone who is HIV negative. Yes. So that's very possible. And you can actually have children if you're discordant as well.
Okay. And the kids, how does that work now with the like when they're babies? Do they have to be on some form of treatment as well, or automatically then they are born negative? How does that work?
Okay, so firstly, it's what we call it PMTCT cascade, which is prevention of mother-to-child transmission of HIV. So there's a whole process. So firstly, say one partner is diagnosed as HIV positive. The first thing is we initiate on treatment, and then the goal is that there's adherence with the goal of getting to viral suppression.
Okay.
Yes. Okay. So that viral suppression is reducing the amount of HIV in your blood. Okay. Yes. Okay. So, for example, we say you're virally suppressed if the amount of HIV in your blood is below 50 copies per milliliter in your blood. Okay. So that's undetectable. Okay. Yes. So nowadays, the buzzword in our field, I'm sure you'll probably hear it and you've seen it on billboards, is undetectable. Undetectable equals untransmittable. U equals U. So that's why, yes. So if you're virally suppressed, that means that the HIV in your system is undetectable, which means you cannot pass HIV to another person. So U equals U. So you can actually be in a relationship with somebody who is negative and you're positive, or you are negative and the person
remain
is positive.
Negative.
Yes, and then you can have. So from there, that's when we now start talking about having children, family planning. So now, say it is So say, for example, it's the woman who's HIV positive, and the husband is HIV negative,
Yes.
and you want to have a child. So we encourage adherence throughout the pregnancy,
Okay.
and viral suppression is our goal, is what we're trying to achieve. And then what we do then is when the child is born, even if both couples are HIV positive, when a child then is born, we make sure that there's early infant diagnosis. The child is tested at birth for HIV, and hopefully, fingers crossed, the child is negative. So usually if you are adhering to treatment, you can't pass HIV to your baby. Yes.
That's nice.
So research has shown that, so you can have HIV negative babies.
Yes, and then Dr. Emma, there's something that I've heard. I don't even know if it's still true or it was back in those days. Then would hear that the moms, they should not breastfeed the baby. At least they pass on the virus to the baby.
Oh yes, that was back in the day.
Okay.
yes. With
Now it's fine, they can breastfeed.
there's a bit of caution there.
Okay.
So we say it's exclusive breastfeeding only. If you are living with HIV and you are on treatment, adhering to treatment, then you can exclusively breastfeed for 6 months.
Okay.
Yes.
Okay.
So why we say exclusive, you can't mix, no water. You can't give the baby water, you can't give the baby porridge, you can't give the baby formula.
Okay.
Yes. Mixed feeding increases the risk of HIV transmission from the mother to the child.
Is it?
Yes,
That
because
is
you're now
so
you're
interesting.
diluting the breast milk.
I
Yes,
see.
the breast milk has its own protective
I see.
components.
Okay.
Yes, and its own immune building components. So the minute you introduce mixed feeding, any other elements, then you are compromising
The child
the
now.
child.
I
So we only say exclusive breastfeeding, EBF, when you're living with HIV. But it should be accompanied by adherence. Yes. So it's quite tricky, right?
It is very tricky.
Yeah, but it's very doable.
Okay.
Where I work in the rural Eastern Cape, I am working with a cohort of 6,000 women and babies. And I think from our cohort, we have about 80% of them are living with HIV. And since 2016, we have only had one baby that was born with HIV.
Oh,
And
wow.
our mothers exclusively breastfeed. Most of our mothers exclusively breastfeed.
Oh, that's
And we support.
nice.
It's really about the support and encouraging. So it is
Yes.
possible. 6,000 mothers and babies
are fine.
are fine. Yes.
That's very interesting. Okay, so now moving on, you did touch on the treatment. Do you want to elaborate more on that, on the treatment, or is it just like the tablets and must I take them for life, or there's a point when I say, okay, now what did you say? I'm
Your viral load.
Yes. So now I can stop. Is that advisable to?
So back in the day, we had like option A, option B plus, which were the different options for
Yes.
HIV treatment. But now we are now in the era of universal test and treat. So which means also it's not about viral load. Everybody who tests positive should be initiated on treatment. Secondly, treatment is for life. You don't stop.
You don't stop.
Yes, treatment is for life,
even
no
if
matter
it's
what.
now detectable, then you still have to.
Yes.
Okay.
The minute you stop, the virus starts replicating in your body. And then if you are also not adherent to your treatment, so adherence means taking your treatment every single day and being consistent. So we talk of correct and consistent taking of your medication. If you're not adherent, you are also risking resistance, viral resistance. So if the HIV virus in your body gets resistant to your medication, then now we're talking about different lines of treatment. So you become a complicated patient.
Yeah.
So for example, when we talk about the ART regimen, antiretroviral therapy regimen, we've got the first line, second line, and third line of treatment.
Okay.
And clinicians, like I said, I'm not a clinician, but clinicians are really pushing to make sure people stay on the first line of treatment.
Oh.
So if you become if you become resistant, right, because you were not taking your treatment well, you were at these stop-starts, you might end up being switched to second line. And so the idea is to keep people on the first line of treatment, which is what majority of the country is on.
So is it one tablet that they take, or a lot of tablets, and is it taken 3 times a day or just once a day, and must you stick to the times that you take this?
So thankfully, we are with advancements in the HIV field, we are now on what we call FDC, which is the fixed dose combination. So before it used to be 3 tablets. So it used to be 3 tablets that you take. Now fixed dose combination is 1 tablet. So all 3 medications are on 1 tablet. You take 1 tablet once a day. Yes, and that's good enough.
So it doesn't matter, today I can take it in the morning, tomorrow in the evening, or there has to be some consistency?
So we try to take it at the same time every day. So doesn't necessarily have to be 8 a.m. every single day,
but in the morning.
Within, say, between 7 and 10 a.m. if you take it around that time. Some take it at night before going to bed. And also something important, for newly initiated people who are newly initiated on treatment, we also encourage that they take their medication at night. There's a lot of side effects, especially when you're starting. Your body it does react a little bit to treatment, and I think we often struggle with people when they are initiated on treatment because they struggle with the side effects and tend to want to stop taking treatment. But that's the same with any medication. TB medication is the same. You know, all medication has side effects. So we try to say with HIV medication ART, we try to say take your treatment at bedtime.
When you at least you sleep.
Yes, the side effects, because there's a lot of reports on nausea, on dizziness, on sweating, loss of energy. Your whole body it's almost like it's going into a shock the first time when you start taking antiretrovirals.
So how long is that period on average when your system, will then adjust? Is it 3 months? Or it depends on the person?
I'm not too sure clinically, but I think it differs. What we've seen, especially with the pregnant mothers, is some people actually have 0 side effects. It just depends with your body. But we've seen some, mostly it's within a week, then they're fine after a week. So it's mostly within a week. Some have rashes, some throw up, but after a week their system, because then the medication is now in the system, it starts being well tolerated.
So there's PrEP and PEP.
Yes.
Do you wanna elaborate on that?
Okay, so that's the latest as well. I mean, we're making so many advancements in the HIV field. So PrEP is pre-exposure prophylaxis. Those are antiretrovirals that you take to prevent getting HIV. Yes.
So who do you recommend this to? Should everyone just take them, or what?
Well, I'll say recommendations and guidelines. So, PrEP was rolled out in South Africa.
Okay.
Zimbabwe was actually, it was rolled out in Zimbabwe before South Africa,
Oh,
actually.
is it?
Yes.
Okay.
So with PrEP, it started with adolescents, young people, and a lot
Oh.
of the research was done with young people because they're the ones who are at mostly the highest risk.
Yes.
And then also with other high-risk population groups as well, like commercial sex workers,
Yes.
MSMs. Yes, there's a whole range. But now PrEP is available at facilities, at our health facility, our mobile clinic where I work. We do provide PrEP. We initiate people on PrEP as well.
So, talk to us about PrEP. Do I have to take it for a certain period? Is it just one injection? How does it work?
It's similar to the antiretroviral therapy for yes. So it's tablets that you also have to take daily.
For life?
Yes. Well, if you want to be HIV negative and you are exposed, yes. Yeah. So you do take PrEP every day to prevent getting HIV. So we encourage adolescents to take PrEP every day as well.
And they can't stop once they start taking it?
You can. With PrEP, you can.
Oh,
yes. No, with PrEP, you can stop. So it's not necessarily for life.
Okay.
But we encourage that you take it and then you just continue. Just so that your body remains able to prevent HIV infection, because how PrEP works is it creates a buffer as well to prevent HIV from entering. Yes.
Okay. And then now PrEP?
With PEP now, PEP is post-exposure prophylaxis, which is a medication that you take after being exposed to somebody who is potentially HIV positive. Yes. So say after a sexual assault, mostly that's where you find people taking PrEP, like at the Tutuzela centers, the Tutuzela rape centers. People are given PrEP.
And should they take them for a certain period?
Yes. So you take PrEP is, I think it's about 28 days.
Okay.
You take 28 days or 1 month, you are on PrEP.
Okay.
Yes, and during that time you're also getting tested for HIV.
Yes.
So it's supposed to, and what we encourage is that you need to take PrEP within 72 hours of exposure. Yes. Yeah, anytime between 2 to 72 hours of exposure for it to actually work.
Okay, all right. So now we're moving on to, this how we can support our relatives, because I'm just thinking it's not a death sentence, once you get your diagnosis that you are now HIV positive. So how can we support our loved ones, who've now gotten this diagnosis? Of course, I know, like you're saying, let's say they've now decided to confide in me. How can I support that person?
I would say the starting point, I think, is also with all of us.
Yes.
The actual starting point is, let's normalize talking about HIV.
Yes.
And let's talk about HIV. We say HIV is a chronic condition. It's like any other chronic condition.
It's like somebody who's got
diabetes.
Blood pressure.
Blood pressure medication. So for all of us, that is our biggest call for communities, and that's what we do in our communities. We try to challenge stigma, around HIV. People have, right now we are talking about aging with HIV. We have people who are reaching their 70s with HIV. So there is nothing, people need to understand that firstly. And families, I would say families need to just start normalizing and talking about HIV as the first starting point. And then I think the second thing is confidentiality. I think that's important. When somebody discloses their status, it's very important to keep that confidential. Because if they have disclosed it to you, it means there's a certain amount of trust,
yes.
and they're needing support from you. They're not looking for you to then share with anybody else the status. I think the third thing is for you to also be strong for them. If you don't know about handling HIV or how to support, I would say people should also educate themselves and understand. We have come from the era of, we're no longer in the AIDS era. It's HIV. It's
HIV,
not AIDS.
I see.
It's not
It's
AIDS.
now a completely different era.
Yes. So people should also educate themselves and try to understand so that you can better support the person who has confided in you. And then I would say just be there for them. I think that's the important thing. Be there for them. It's a lonely journey. It can be very scary. People tend to isolate. People tend to go into depression. 1 minute they're okay, and then the next minute, so try to be there for them. And we always talk about, because like I said, I'm not a clinician. We look at the social aspects, and we always say from our side, there is more to HIV, there's more to life than HIV, than your status and your diagnosis. So also, that's how you support somebody. See them as for who they are and not for the diagnosis, right? So that means when you're spending time with them and being there for them, it's not about, oh, how are you feeling today? How is your medication? No, just live life, enjoy life, give meaning to them. They need to have a reason to live. So that's the important thing that we work with adolescents, for example, who are living with HIV. Our biggest thing we always say with our young people is, our goal is to give meaning to them, a reason to live. And normally, that's what somebody who's been diagnosed with HIV is looking for. They're looking for a reason to live. So give them that, remind them. I mean, if they're Christian, bring them back to the word. That's very, very important. Yes, because that can actually make a difference. We have people who've spiraled and, to a point of no return, and some become suicidal. We lose people because of just that,
Thank you so much, Dr. Emma, for covering this topic for us. I hope most of us are now well informed, and now we can support, our families. And if you ever get diagnosed that you are now HIV positive, it's not a death sentence. There's a lot to live for. So there's hope. There's hope, and you must just remain anchored in the Lord, and God will take care of you. Thank you so much.
Crazy.